Hi, everyone, and welcome to today's session, From Guideline to Action, Key Takeaways from the 2025 AHA-ACC High Blood Pressure Recommendation. I am Burton Melnick, and I have the privilege of chairing the National Forum and kicking off today's webinar. Since it is 9/11, I would like to take a few seconds to just pause and think about the victims and their families who suffered this terrible tragedy. We are thrilled to have such a strong turnout of clinicians, researchers, public health professionals, and community leaders with us today. Together, we will explore the newly released guideline, which has changed what is new, and very importantly, how we can put the guideline into action to improve cardiovascular health across America. Next slide, please. Use the chat function to say hello, offer comments, and engage throughout the meeting. We will also be dropping in useful links. Please share your questions through the Q&A button at the bottom of your Zoom screen. Later in the program, we will have an open forum with the live Q&A. Next slide, please. I was so blessed to serve on this guideline panel because I've always had a strong philosophy: in God we trust, but everybody else better bring data to the table. Before diving into the details, I'd like to recognize the extraordinary work of this guideline writing committee, led by Dr. Daniel W. Jones and Vice Chairs Dr. Keith Ferdinand and Dr. Sandra Taylor. This multidisciplinary team was comprised of expert cardiologists, primary care providers, nurses, pharmacists, and public health leaders. Their dedication ensures the guideline is evidence-based, practical, and clinically relevant. The guideline outlines a comprehensive evidence-based process for developing and implementing updated recommendations for hypertension management. It replaces the 2017 guideline. Next slide, please. It involved multidisciplines, again, experts in their field. Today's discussion is not just about what is on paper. It's about how the guideline can transform practice and save lives. With that, I am pleased to transition us after I just remind everybody about the classifications of blood pressure. Please note on the next slide, the numbers we really want to remember are 130/80. Next slide, please. In adults, blood pressure should be categorized as normal, elevated, or stage 1 or 2 hypertension to prevent and treat high blood pressure. Next slide, please. I'm not going to read you these particular categories. Again, I really want to emphasize 130/80. I'm going to finish before I transition to Dr. Ferdinand by sharing why I am so deeply passionate about blood pressure control. I was 15 years of age, home alone with my mother when she sneezed, stroked out, and died right in front of me. I suffered from terrible post-traumatic stress disorder, depression, and anxiety. But the saddest part of my mother's story, she had seen her primary care physician just a week before she died, because she had been suffering from terrible headaches. And my dad kept saying, please go to the doctor, figure out what's wrong. Well, she was diagnosed with high blood pressure by her physician 1 week before she died, given a prescription for a blood pressure medication that my dad found in her purse after she died. Think about this. How many people throughout the United States have high blood pressure, and only 1 out of 4 have it under control? With those comments, I am fortunate to be able to introduce one of the foremost experts in cardiovascular health, who will provide a comprehensive overview of the new guideline. Dr. Keith Ferdinand is a professor of medicine at Tulane University School of Medicine. He has dedicated his career to advancing cardiovascular care, prevention, and health equity. He served as a wonderful vice chair of our 2025 guideline writing committee. Dr. Ferdinand will review the guideline, highlight what's changed, and explain what these changes mean for clinical practice and patient care.
Thank you so much, Bernadette, and thank you for the courage of sharing your personal story, which should monitor for all of us the need to control blood pressure, the most potent and prevalent cause of the #1 cause of death in the United States and really worldwide, hypertension. Let's go to the next slide. I'll move along quite quickly. Here's the writing committee members coming from various organizations throughout the United States. I'll give some historical context of the 2017 guideline and why we have a 2025 high blood pressure guideline. I'll discuss some updates and rationales. For the first time, we're using the Prevent Risk Calculator for CV risk assessment, and I'll give you an example of how to use that tool. We'll talk about primary aldosteronism, resistant hypertension, secondary hypertension, and some interesting special populations, pregnant individuals, persons with diabetes, and CKD, and make at least one comment on patients with obesity, including the GLP-1 receptor agonist. When you look at the guidelines, they use the same classifications for the level of evidence that's used in other AHA, ACC multi-society guidelines. So you'll hear class 1 being the strongest, class 2A being moderate, class 2B being somewhat weaker. And when you see class 3, it means don't use it. And you'll see some discussion of the level of evidence, but I'll mainly talk about class 1, 2, and a few instances of a class 3. So how do you use this guideline? Well, first of all, those of you who are practicing clinicians or researchers may want to read it thoroughly. It's a good update. For those who don't have that much time, you can go and read the top 10 takeaways and what's new. We actually called that out to make it easier to digest. You also can just look at the box recommendations, and I'll show you those. That's where we have the class level of evidence. Or you can use it as a reference. At any time for a specific thing, you may want to go to this vetted reference regarding high blood pressure and hypertension. Remember, it's written for clinicians, by clinicians, based on evidence. And also recognize that we're using it not only for diagnosis, but I will discuss when you should initiate medications and what is the blood pressure goal. For most persons, it's going to be less than 120/80, but we now have new evidence coming from some large randomized trials, mainly from China, that if you can, it's better to achieve a blood pressure less than 120. So the goal is the same, ideally less than 120. Here are the blood pressure categories that Bernadette has already described. I built on top of that severe hypertension and hypertension emergency. Unless the person is having acute symptoms, it's no longer necessary to go to the emergency department and get parenteral, IV, or IM medications or clonidine. Many patients just need their medicines restarted or up-titrated, even if they have severe hypertension. Another thing on laboratory testing, which is new, we've added urine albumin to creatinine ratio. It used to be termed microalbuminuria, and it's an indication that that person has early CKD, even if the GFR is normal, and it is an indication for an increase in cardiovascular risk. So when we get to the PREVENT calculator, you'll note that we suggest that you use the urine albumin creatinine ratio as another risk assessment. Here's the central cartoon from the PREVENT recorder. I'll go around the clock, starting at the top: age, sex, blood pressure, cholesterol, medication, diabetes, tobacco. But we also add kidney function with the urine albumin creatinine ratio and the social determinants or the social drivers of health, where people work, live, play, and pray, using zip codes for the social deprivation index. Of course, we add the A1C if the person has diabetes or prediabetes, but the urine albumin creatinine ratio, although the original PREVENT risk calculator says when indicated, for the purposes of the AHA ACC blood pressure guideline, we want urine albumin creatinine ratio on all patients with high blood pressure. Here's an example of how you would use the PREVENT online recorder. This is a 35-year-old guy who has his lipids there. They're not bad. Stage 1 blood pressure, 136, normal BMI, so not overweight or obese. The GFR is 94, so that's normal. Always ask about smoking, whether the person is using medications for blood pressure or lipids. And in this particular case, although the PREVENT calculator mentions that there are some personalized approaches as predictors, we suggest all patients get a urine albumin creatinine ratio. This one is normal at 15, abnormal being 30 or above. So using this approach, the calculated 10-year CVD risk is 1.3%. We use the cut point of 7.5% or greater. So this is a low risk, stage 1 hypertension patient. One of the questions that has arisen is, well, are we going to then undertreat patients? This is an analysis that was done looking at the Prevent calculator and comparing it to the 2017 blood pressure guideline using the pooled cohort. And the numbers of patients who will be eligible for antihypertensive therapy are really about the same. That includes patients with stage 2 hypertension, cardiovascular disease, diabetes, or CKD. So when you compare the pooled cohort, the 10% or greater risk calculation is equal to the Prevent risk calculator of 7.5%. It sounds a little odd, but remember, Prevent takes into account not just atherosclerosis, heart attack, strokes, but now adds heart failure, an emerging risk factor for cardiovascular disease and death. So it's a broader approach to risk. This paper is available, published. There's the working group. Many of the same persons who on the guideline committee did this paper to show how we can use the Prevent recorder to assess risk. This bar diagram depicts, therefore, that the 2017 ACC-AHA high blood pressure guideline and the 2025 guideline are very similar in the numbers of persons who will need treatment. We take in blue those patients with stage 1 hypertension and older age and merge them into a higher risk category, therefore increasing those patients who need treatment. The number of persons remains the same. In the guideline, you'll see these take-home messages. They're pithy, they're easy to remember. High blood pressure is prevalent and the most modifiable of all the potent cardiovascular risks. It affects coronary disease, heart failure, atrial fibrillation, stroke, dementia, and I'm going to call that out in a second, chronic kidney disease, and all-cause mortality. And the overarching concern is we get patients less than 130/80, but reasonably, if a person is institutionalized and has limited life expectancy, there's also a different guideline goal for persons who are pregnant. But other than that, everyone 130/80. The Prevent recorder, therefore, uses the cut point of 7.5%. If it's less than 7.5%, they still need therapy, but we start with 3 to 6 months of lifestyle intervention before medications for the low-risk patients of less than 7.5%. On the other hand, if the person is stage 2, 140/90 or above, or even if they're just 130/80 and above, but they have clinical cardiovascular disease, previous stroke, diabetes, chronic kidney disease, or a 10-year predicted risk of 7.5% or greater, then you initiate treatment in those patients immediately, continuing, of course, therapeutic lifestyle changes, but medications immediately. Here's another take-home point. Most patients who have stage 2 hypertension are going to need 2 first-line drugs, often in combination. And for the first time, we recommend a single pill fixed dose combination if available. We think it will improve adherence and achieve a better blood pressure quickly and over time. I mentioned in my opening remarks that there was a new recommendation regarding intensive blood pressure control to reduce the risk of dementia. We now have multiple studies, including a large study out of China, showing that if you lower blood pressure less than 130/80, but optimally less than 120, in the middle-aged to older population, you can reduce the risk of dementia 12 to 19%. Here's those box recommendations. This is a class 1A, the highest level. For patients with hypertension, a goal of less than 130 is recommended to prevent mild cognitive impairment and even dementia. We think this will drive patients to seek care and help clinicians overcome therapeutic inertia. Here's some more box warnings. A class 1, to manage blood pressures using appropriate measurement. The National Forum for years has suggested that we're not measuring blood pressure appropriately. And a class 2A, we would prefer that you use the oscillometric automatic blood pressure devices versus the auscultary. We as clinicians sometimes think we can do better by hearing the blood pressure, but the data seems to indicate that a valid automated device is the best approach. These cartoons are in the guideline. The National Forum has addressed this for years. When you have a person, make sure that they don't have any caffeine, exercise, resting 30 minutes. blood pressure, appropriate device, validatebp.org, bare arm, supported at heart level, sitting in a chair with the back, legs not crossed. The clinician nor the patient should be smoking, and it should be done in a temperature-controlled room with the patient being comfortable, 2 or more blood pressures, and then average those. This particular approach to office blood pressure is very similar to recommended home blood pressure monitoring in the guideline. Furthermore, class 1, we suggest that we do out-of-office blood pressure using either ambulatory blood pressure monitoring or home blood pressure monitoring to confirm the diagnosis of hypertension. And if the patient is taking medicine, we use it to up-titrate or change medicines. Note we give a class 3, red, harm, don't do it. Use of the cuffless blood pressure devices is not recommended for the diagnosis or the management of high blood pressure. Here's the algorithm. The person has confirmed hypertension. Do the 10-year ASCVD risk as done by Prevent. If the blood pressure is less than 130, you're getting there, but we really want you ideally less than 120. On the other hand, if the patient does not have ASCVD risk, then it's still less than 130, but we want you to wait for 3 to 6 months of lifestyle intervention, and the medication then becomes a 2B consider. Here's the box warning. Systolic is on the top, diastolic on the bottom. Low risk, less than 7.5%, 130 over 80, 3 to 6 months of therapeutic lifestyle changes, including a DASH diet, low sodium, potassium supplementation when needed, to prevent target organ damage and mitigate further rise in blood pressure. Now, if you're going to use medications in these patients, what medicines you should use? Looking at the evidence, we chose these particular classes. Thiazide type diuretic, which is a term of art. It includes chlorthalidone, indapamide, and hydrochlorothiazide. Long-acting dihydropyridine calcium channel blockers, and ACE inhibitor or ARB. We recommend those equally for the control of blood pressure, although we know in comorbid conditions such as heart failure with reduced ejection fraction or HFrEF, ACE inhibitors have more data and perhaps more data post-myocardial infarction. But for the control of blood pressure, ACE inhibitors or ARBs are all included as first-step agents. Here's the box. Class 1A, when initiating antihypertensive agents, use a thiazide type diuretic, long-acting dihydropyridine calcium blocker, ACE inhibitor, or ARB. And here's the algorithm. Stage 1 hypertension, consider medication after 3 to 6 months of lifestyle modification. Stage 2 hypertension, 140 over 90, start medications immediately, or stage 1 with high risk, including cardiovascular disease, chronic kidney disease, diabetes, start medicines immediately. And at no stage should you combine an ACE inhibitor, ARB, with a renin inhibitor. So let's work through the algorithm of a patient. First question, does the patient have 140 over 90? If the answer is no, then look for cardiovascular disease, coronary disease, stroke, heart failure. If the answer is no, look for diabetes or chronic kidney disease and do the Prevent cardiovascular risk calculation. If it's not greater than 75, then you have 3 to 6 months of lifestyle intervention, but then we suggest utilizing medication. On the other hand, if the blood pressure is 140 over 90, initiate medication. If the patient has cardiovascular disease, yes, initiate medication. If the patient has diabetes, chronic kidney disease, or if you use the Prevent CVD risk calculator and it's 7.5% or greater, yes, initiate antihypertensive medication. Here's the box directly out of the guideline. These are persons who have chronic kidney disease, a class 1A evidence. You got to do it. If the person has CKD, and we define it as a GFR less than 60, or albuminuria equal to or greater than 30 milligrams per gram, so that used to be called microalbuminuria, then we suggest treat to a goal of less than 130 and consider the use of a RAS blocking agent, either an ACE or an R, but of course not both together, the purpose of which is to decrease cardiovascular disease and delay progression of CKD. What about patients with diabetes? If a person has diabetes, the debate is over. We initiate medications if it's 130 or above with a goal of less than 120, and we encourage you to seek a systolic blood pressure, a goal of less than 130, and a encouragement to seek a systolic blood pressure less than 120. You can use any of the first-class antihypertensive agents that we described, the thiazide type diuretic, long-acting calcium blocker, the ACE inhibitor, or the R. But if the person with diabetes has a GFR less than 60, or if they have the presence of albuminuria, 30 milligrams per gram or above, we suggest an ACE or an ARB, and we use those equally as a recommendation. I mentioned in my opening remarks for the first time, we mentioned some data on GLP-1, and we suggest it's a 2B. You may consider, in persons who are overweight, obese, BMI of 27 or above, using incretin therapy, a GLP-1 receptor agonist, to assist with weight management, and it has been shown to be a good adjunct to lower blood pressure. Of course, we have to overcome the barriers of cost and availability. Furthermore, if the person has obesity and a BMI of 35 or greater, we also say you may consider bariatric surgery as part of your antihypertensive therapies. Let's walk through now secondary hypertension. There's a list of various conditions that can cause secondary hypertension or give to your attention secondary hypertension. I'm not going to go through this list. It's in the guideline, but let's walk through the algorithm. First, ask the question, does the person have these various conditions? If no, you don't need to screen. If yes, then consider primary aldosteronism, which we know in difficult to treat and resistant hypertension may be as common as 20% of patients. If you then have a positive screen for aldosteronism, we suggest you refer to someone who has expertise in these difficult to treat patients. Here's the box regarding primary aldosteronism, class 1 in patients who have resistant hypertension, regardless of whether or not hypokalemia is present. It includes patients who have, of course, spontaneous hypokalemia, obstructive sleep apnea, an adrenal mass, a family history of early onset hypertension, or having a stroke before the age of 40. Think about primary aldosteronism. A 2B, you may want to consider any patient who has stage 2 hypertension for primary aldosteronism. Here's further box recommendations on primary aldosteronism. Screen for plasma renin, aldosterone, and then do an aldosterone-renin ratio to see whether or not aldosterone is really present. New, you may continue most of your antihypertensive medicines. We no longer suggest you stop everything other than the mineralocorticoid receptor antagonist, that's spironolactone or eplerenone. The other medicines you can continue and get the plasma aldosterone-renin ratio. And if the person does have a positive test for primary aldosteronism, we suggest then you refer to a hypertension specialist or an endocrinologist, someone who could do further evaluation and treatment. Here's the algorithm for resistant hypertension. The patient is uncontrolled on 3 or more medicines at maximally tolerated doses, one of which is a diuretic, or if it takes 4 drugs to control that patient. First, exclude pseudo-resistance, pseudo meaning false, using poor blood pressure technique or the patient's not adhering. A patient who doesn't take medicines, it won't work. Identify reverse lifestyle. Look for other agents that may be elevating blood pressure, including things like over-the-counter NSAIDs, non-steroidal anti-inflammatories, stimulants, especially during the flu and cold season. Then at that point, look for secondary causes of hypertension. The patient's blood pressure is uncontrolled on 3 or more medicines at maximally tolerated doses, one of which is a diuretic, or it takes 4 medicines to control. You may want to consider replacing hydrochlorothiazide in those patients with chlorthalidone or indapamide. And there's good data if the GFR is 45 or greater, you can safely add a mineral-corticoid receptor antagonist, spironolactone, or ipirlinone. If the patient can't tolerate a mineral-corticoid receptor antagonist, you consider amnuride. There are other agents that are available, but they're going to be after these agents. That includes beta blockers, central agonists, non-dihydropyridine calcium channel blockers, and there is a new drug recently approved, aprocitentan, which is an endothelin antagonist for those patients. Now let's move on to a special population. Those are persons with pregnancy and preeclampsia. First question, check the blood pressure. Now here it's not 130/80, but it's 140/90, or as high as 160. Then look for proteinuria, sign that the person has kidney inflammation. Next, look for the presence of other criteria, thrombocytopenia, low platelets, reduced kidney function, impaired liver function, pulmonary edema, or new onset headache. If you have this constellation of elevated blood pressure, proteinuria, and other criteria, the diagnosis can be made of preeclampsia. What medications you should use? If a person is pregnant or considering being pregnant, we suggest labetalol or nifedipine as the preferred agents. In the red, do not use atenolol, ACE inhibitors, ARBs, direct renin inhibitors, nitroprusside, or the mineral corticoid receptor antagonist, class 3 harm. And in those patients who are pregnant, treat to get the blood pressure down quickly if it's 160/110 or and above. For chronic hypertension, start treating at 140/90 versus 130/80. Let me close with a few comments on renal nerve denervation. This was recently approved in November of 2023 after the 2017 guidelines. Class 2B, you may want to consider it in patients who have resistant hypertension despite optimal treatment, or they're intolerable of the present antihypertensive drug regimen. In addition to lifestyle, 2B, you may consider renal nerve denervation. However, class 1, this must be done in the context of a multidisciplinary team. For years, the National Forum has not just been about doctors, but an entire team: nurse practitioners, advanced practice nurses, pharmacists, medical assistants, the patient and the patient's family, all working together to make the decision whether to use this new tool. Well, I covered a lot of data. Perhaps we'll have time and questions and answers to further discuss the 2025 high blood pressure guideline from the American Heart Association, American College of Cardiology, and multi-societies. And hopefully we can control the ravages of high blood pressure, the most potent and prevalent of cardiovascular risk, the #1 cause of death and disability.
Thank you, Dr. Ferdinand, for that outstanding overview of our new guideline. Now let's focus on prevention and healthy lifestyle behaviors, which are the foundation of hypertension management. Lifestyle modifications remain the first-line therapy, and the guideline reaffirms the importance of lifestyle modifications, such as the DASH diet, reducing sodium, increasing potassium intake, physical activity and weight management, stress reduction, and alcohol in moderation if you drink. And then I'm going to touch on the role of community-based interventions, and very importantly, addressing the social determinants of health. Dietary approaches. The DASH diet is excellent. It is comprised of a high intake fruits and veggies, whole grains, low fat or fat-free dairy, lean protein, nuts and seeds, and healthy fats. The recommendation for salt intake is less than 2,300 milligrams a day, which is about a teaspoon of salt. Lower sodium is even better, less than or equal to 1,500 milligrams a day. We want people to avoid added sugars and saturated fats. As far as physical activity, 75 to 150 minutes per week. It should include aerobic exercise, such as brisk walking, swimming, cycling, as well as resistance training twice per week. We know through the body of evidence that regular physical activity can reduce blood pressure by 5 to 8 millimeters of mercury, but it also improves cardiovascular endurance, supports weight loss, and a good target with folks. Let's focus on just a 5% reduction in body weight. Lastly, we've got to help people reduce stress. We often don't screen for stress in primary care practices or other types of clinics. Please. For stress reduction, meditation has a lot of evidence behind it. Control, deep abdominal breathing, yoga, mindfulness practices. And if you don't drink, don't start. That is alcohol. But if you drink alcohol, it's incredibly important to limit it to 1 standard drink a day if you're a woman, 2 if you're a male. And people often ask me, how big can those drinks be? The answer is not the size of the alcoholic beverages we get in Vegas. Next slide, please. The role of community-based interventions is exceedingly important. They are vital because we can reach underserved populations. We can promote early detection and prevention. Community-based interventions can enhance adherence to lifestyle and medication plans. And finally, we can reduce health disparities with community-based interventions. I'd like to just highlight our national forums, Move with the Mayor, national initiative, as a great exemplar of community-based intervention that is making an incredible positive impact. We now have had over 200 participating cities between 2014 and 2025. We held a Move with the Mayor Spring Challenge this past spring. We had 50 participating cities hosting more than 100 events. Our plan is to keep growing Move with the Mayor because of the positive impact that it is showing across our entire country. Next slide, please. We have to keep integrating social determinants of health as key in blood pressure control. By integrating the social determinants of health, we improve access to medications and healthy lifestyle resources. We enhance adherence to treatment. And very importantly, we reduce health disparities. So I'm going to lastly focus on putting the guidelines into action with implementation strategies. We know since the famous Bayless and Boren paper that came out in 2000, that it for so long took at least 17 years to translate findings from research or an evidence-based guideline into the real world. But a recent study was done that showed in 2 decades, we have reduced the research practice time gap by 2 years. So now we say it only takes 15 years to translate high quality guidelines into practice. Well, at that rate, it's only going to take us 150 more years to produce a terrific evidence-based guideline, and everybody across the nation immediately put it into action. I want to remind all of us that the gap between what we know and what we do is lethal. We also need to de-implement what isn't working or based on best evidence. So key implementation strategies. Dr. Ferdinand talked about multidisciplinary team-based care. That is so important, but a lot of providers are still functioning in silos. It's critical to collaborate with community leaders and organizations to encourage home blood pressure monitoring with validated devices. The new Apple Watch will be able to measure blood pressure, but validation needs to happen with cuffless devices. And in patients that have their hypertension, needing to have it under control, single pill combinations can really improve adherence. But we have a lot of what I call character builders in clinical practice. Low rates of blood pressure control. It's staggering to think only 1 out of 4 people with hypertension have it under control. Underdiagnosis of secondary causes, resource constraints, limited use of team-based care, gaps in translational research, promising areas that have yet to create better practical tools. We still have technology limits, but a big, big character builder is motivating behavior change in people. That is truly character building. This is a real fitness facility in the state of California. You have a choice. You can walk the stairs or take the escalator to work out at the gym. Two psychologists were interested in monitoring how many people during the course of a day, during a 7-day week, chose the steps instead of the escalator. They're finding only 2 people a day. Most people don't change unless, unfortunately, crisis happens or their emotions are raised. So we have to give people evidence plus emotional story to really get them to think about making a healthy lifestyle change. Opportunities in clinical practice using the prevent risk calculator, single pill combination therapy, community-based care, expanded screening for hyperaldosteronism and kidney function, lifestyle modification, and then pregnancy-specific guidance. So I want you to think about your own healthy lifestyle behaviors. We know it takes an average of 30 to 66 days of consistent practice to make or break a new health habit. I encourage you attending today. Make today your January 1 for your own personal cardiovascular health. And in addition to that, go back to where you work in the next 30 days. Gather a team and say, when and how are we going to get the new guideline implemented? So with that, I'm going to turn it over to our wonderful CEO of the forum, John Clymer. I think John is having a character builder right now. And
well, Bernadette, can you hear me?
Yes.
So while we're waiting for John to come in, because we want to stay on time, someone mentioned the Sprint Mind study regarding the combined dementia and cognitive decline. Yes, it did show that. Remember, Sprint Mind was stopped early, so it really didn't meet statistical power for its primary outcome. The Chinese rural hypertension study was huge, over 33,000 persons. It met its primary outcome. I think it showed the same thing as Sprint, but because the primary outcome was met, you actually can give it a little bit more emphasis, and that's why we made it a definite call out in the new guideline. Combining Sprint and the Chinese study, now you're talking over 40,000 persons. We are very clear that treating blood pressure, middle-aged, older persons will help with cognitive decline and dementia, and we think that will drive people to more care.
Thank you, Dr. Ferdinand, and thank you to Dr. Walter Koroshetz, the director of the National Institute for Neurological Disease and Stroke, for posing the question or bringing to our attention the Sprint Mind study and its findings. With over 150 people participating in this briefing, we have a lot of questions. We have a short time to get to them. So some of them, fortunately, were preemptively answered by Doctors Melnick and Ferdinand, but we want to get to as many of the questions as possible. So I'll ask our experts to try to give brief answers so that we can get through them. The first question is from Dr. Robert Block from the University of Rochester, who asks about home blood pressure measurement. And I'll build on that just a little to ask, how does the new guideline affect the self-measured blood pressure protocol?
Well, we suggest out of office a home blood pressure for everyone to confirm the diagnosis. Although it's a very powerful and potent biomarker, it's done poorly in the clinic setting. And we think the combination of home blood pressure plus office blood pressure will confirm the diagnosis and help us titrate. You also will look for masked hypertension. I've practiced long enough where we said that patients were just fooling themselves that their blood pressure was only high in the clinic, but we now know using ambulatory blood pressure and validated home devices that anywhere from 10 to 15% of persons, they were right. And those persons are at some increased risk, but we may not treat them as intensively with pharmacotherapy immediately.
Thank you, Dr. Ferdinand. Warren Jones, past president of the American Academy of Family Physicians, has a tough question. How do you recommend obtaining combination hypertension medications for Medicaid patients when there's resistance to combination medications?
Well, I'll let Bernadette address overcoming therapeutic inertia and talking to patients, because I think that's the problem. But as clinicians, you know, the Million Hearts on this particular platform has said that if you go to their website, they actually have a list of Medicare formularies across the United States where combination therapies are available generically at a relatively low cost. So the medicines are there. Bernadette can talk about overcoming the barriers to use.
Yeah, I think for one, as clinicians, we feel good when we provide education to our patients, and it's necessary to raise awareness. But just because we provide education, that doesn't translate into behavior change. And as clinicians, personally, as an NP, I think it's so key. Again, we've got to assess well, including stress. We have got to work with people on motivational interviewing because, again, 80% of chronic disease, including blood pressure control, is modifiable with healthy behaviors. That's not easy. It's a real challenging piece of practice, but it's something we need to improve in.
Thank you, Dr. Melnick. Steve Sidney asks about ages here. We just saw yesterday in the Wall Street Journal that premiums next year for employer-sponsored health insurance are going to increase at the highest level in at least 15 years. And one of the reasons given for that is increased treatment of people with chronic disease earlier in their lives when they are working age. And that ties, I think, to Dr. Sidney's question, which is the guidelines focused on adults ages 30 and above. Do you have comments about screening and treatment in children and young adults?
Full name of the guidelines includes the words in adults. We particularly wanted to address adults because that's where we have the most robust data. As many of you may know, I'm an endowed chair from the Gerald S. Berenson Endowed Chair at Tulane. Dr. Berenson, the late Dr. Berenson, showed that these risk factors actually start in teenage and pre-adolescence. I think the way to treat these children is going to be mainly through lifestyle, physical exercise, reducing sodium intake, increasing potassium intake, the DASH-like diet, and weight loss when appropriate through a combination of calorie restriction and exercise. Once the person becomes adult, then we have more data, increasing data, that treating them is beneficial. There is a 30-year risk part of the PREVENT calculator. We really don't know how yet to apply that to younger people, but it's there. You can still do a 30-year risk calculation for anyone who's 30. Prior to that, I think just a sensible approach, as Bernadette has shown, to lifestyle intervention is the way to go.
Thank you, Dr. Ferdinand. We're going to get to some more questions, but before we do, I'm going to ask a member of the National Forum team to drop into the chat a link to an evaluation of this briefing. We want to know how useful this is to you and how we can make future briefings even more valuable to you. So please take a moment to fill out this evaluation right now while everything is fresh in your mind. Click on the briefing or the link that Julie Harville just popped into the chat.
John, I would like to just add a comment about children and teens and their physical activity. There's been a lot of schools across the United States that have eliminated physical education and PA. So we have to remember too, how can we best use the evidence to inform policy change and be the strongest advocates that we can with that?
Thank you, Dr. Melnick. Yeah, I think it's important for us to note consistently when we're talking with policymakers that the guideline is based on gold standard science. And it's something that everyone can trust and have faith in. Claire Rabbit asks, is it better to take blood pressure measurements in the morning?
Well, we know the surrogate for ambulatory blood pressure, if you don't have that device available where the person can wear the device and take it home, is to do home blood pressure 2 times in the morning, 2 times in the evening for at least 5 to 7 days. And it's pretty good. You're not going to get the same nocturnal blood pressure because you're not going to wake up in the middle of the night and check it. But it's a surrogate for the blood pressure load, 2 in the morning, 2 at night. Once the person is stable and the blood pressure has been confirmed using a valid device, I don't think you necessarily need to continue that after 1 to 2 weeks. But for a first diagnosis available, and I see a lot of my friends in the audience asking questions about things like the barbershop approach. Barbershop approach is okay, but many barbers, they're busy and they have things to do. I think home blood pressure now with the new devices are very portable, instructing the patient how to use it, and ones that are able to keep the numbers so that you can see them. And optimally in the future, integrating them directly into the electronic health record is going to be the way to go. I think you're not going to be able to just bombard barbers for out-of-office blood pressure and get the same effect. And this is from somebody who worked with barbershop interventions decades ago. And I'm not saying it's not an important approach, but the new devices are easy, portable, available. Validate bp.org, and the patient can then integrate those results directly to you.
All right, from Ron Victor to Keith Ferdinand to our ears. Thank you. Several people have asked whether we will be sharing the slides, and the answer is yes, we will. So thank you for those questions. Dr. Melnick, Jeanette Magana asks about postpartum preeclampsia. Does the guideline address that?
Well, the guideline builds on ACOG, and
yeah.
Go ahead. You want to say something, Bernadette? Go.
No, I was exactly going to say that, Keith, that it builds on that guideline.
All right. Thank you very much. And I regret that we are at the top of the hour. This has been so informative. There are more questions that we haven't been able to get to, but we have covered the vast majority of those that were posed. So thank you to our very engaged audience for your questions, as well as for comments and for people who pointed out additional resources that people can use to get more information that will help with implementation. Um, Dr. Ferdinand more than once made the comment that hypertension is the most potent and prevalent cause of death. I think we should add preventable to that. So the three P's: potent, prevalent, and preventable cause of death. The new guideline to manage high blood pressure, I think, will help us do that. Madale Ogunniyi, who's in the audience today and who was another member of the guideline writing committee, often says that we must raise the recognition of the lethality of uncontrolled hypertension. And that ties right in, I think, to Dr. Melnick's comment about the gap between what we know and what we do being lethal. We have a great opportunity to apply the new guideline in community settings and clinical settings. I hope that this briefing by Drs. Ferdinand and Melnick has been helpful to you in identifying things that you can do in your practice or your system setting, wherever you work, beginning next week. Let's not wait. Let's cut that time to implement the new guideline so that we can maximize the positive impact, the beneficial impact on the most people, everyone, everywhere, to quote my friend Eduardo Sanchez. And let's take down hypertension as the most potent and prevalent cause of death. Thank you for joining this briefing today. The National Forum appreciates your participation and is grateful to our experts for sharing their expertise and insights. Please, before you leave, click on that link that Julie put in the chat to the evaluation and take a moment to fill it out. With that, we are adjourned.